Welcome to the Radiographics Podcast. I'm Wendy Gibbs. This week, Dr. Ross Frederick and I are focusing on abdominal imaging. I'm going to partly summarize a great new paper on liver imaging and LI-RADS. So yes, I'm going to talk about my favorite subject, reporting. And Dr. Frederick is going to give us a very useful summary of cystic masses of the abdomen and pelvis. Let's start with mine. How to use LI-RADS to report liver CT and MRI observations. Okay, full disclosure, I don't remember much about liver imaging, but I love this article because it gives me the information I need to make a valuable radiology report, the terminology, the necessary content, and even the management recommendations. This paper starts with a lengthy explanation of the different types of radiology reporting. We tend to call everything structured reporting. And the problem with that is the term has a negative connotation for many. So this is useful information to understand that when we talk about standardization and structure and templates, there are many different ways to do this, and some are much more valuable than others. Say you only see liver cancer or have to describe liver lesions once a month or once a year, or you're a resident just learning and can't remember exactly what you're supposed to say in your report. If I use the terminology and algorithmic assessment provided by LI-RADS, it isn't really a problem. I know what the findings look like, and this reminds me which findings I need to discuss so that my report is complete and useful to the management team. And if I'm in training, this is a great way to learn what's important. Radiology reports come in many forms, including free text, standardized, structured. Free text reports, regular prose reports, which almost everyone here uses, may lack clarity, with individuals using different terms and descriptions of the same entity, and consistency between different members of the same group, different groups, even if you're reporting on a different day. And this can potentially lead to confusion on the part of the ordering team, the patient if they're participating in their care and reading their reports, and other radiologists who may be reading the follow-up studies. Standardization of language. All of us using the same word for the same entity or description, and structure in order to cover all clinically relevant data for a certain pathology, ensures consistent and complete reporting of all necessary data. Primary liver cancer is the fourth leading cause of cancer-related deaths worldwide. The vast majority of these are hepatocellular carcinoma. Imaging plays a central role in hepatocellular carcinoma diagnosis and management. As a result, the content and structure of radiology reports are of utmost importance in guiding clinical management. The Liver Imaging Reporting and Data System, or LI-RADS, provides guidance for standardized reporting of liver observations in patients who are at risk for HCC. LI-RADS provides two templates for reporting liver observations: in a single continuous paragraph or in a structured format with keywords and imaging findings. LI-RADS provides standardization in screening and surveillance with ultrasound, in diagnostic imaging with CT, MRI, and contrast-enhanced ultrasound, and for assessment of treatment response with CT and MRI. In this article, the authors discuss the applicability of LI-RADS and focus on the elements of a standardized LI-RADS report for liver CT and MRI. A structured report template for liver CT and MRI using LI-RADS is available at www.radreport.org/home. Well, I'm not going to give you the number, but go to radreport.org from RSNA and you'll find that and many other templates. The LI-RADS CT and MRI diagnostic algorithm was developed to standardize the imaging diagnosis of HCC. It provides a stepwise approach to assigning a probability of HCC, which is LR1 through LR5, malignancy, LRM, or vascular invasive disease or tumor in vein, LRTIV. To maintain a high positive predictive value for the diagnosis of HCC, the diagnostic algorithm is only used for patients who are at high risk. A companion lexicon standardizes the vocabulary of all aspects of liver imaging. While the use of this lexicon is advocated for the description of liver observations in patients who are at risk for HCC, it's also encouraged for the description of liver observations in all patients. The first step in LI-RADS standardized reporting is to identify the appropriate algorithm. To use LI-RADS, radiologists must first establish that the patient meets the LI-RADS population criteria, namely cirrhosis, chronic hepatitis B infection, even in the absence of cirrhosis, or a personal history of HCC. LI-RADS should not be applied to patients without a previously mentioned risk factor, patients younger than 18, or patients with congenital hepatic fibrosis or cirrhosis due to vascular disorders. Depending on the clinical scenario, users may apply the CT and MRI LI-RADS diagnostic algorithm for untreated observations, the LI-RADS treatment response algorithm for assessing response to local regional treatment of pathologically proven or imaging-presumed malignancies, or both if untreated and treated observations are present. I won't go through this whole thing. You need to look at the paper and apply it to a real case to understand its usefulness. But here are some examples of the information they provide, the findings, and the justification. Let's start with background liver findings. Background liver findings potentially inform the severity of liver disease and may impact treatment options. When available, quantitative techniques such as liver stiffness as a biomarker of liver fibrosis or proton density fat fraction as a biomarker of liver steatosis can help further describe background liver alterations. Reporting the presence of background steatosis or iron overload may be relevant, especially when category adjustments are made by relying on ancillary features. If a patient has undergone a hepatectomy or liver transplant, a description of post-surgical changes should be included. Description of the vascular or biliary anatomy is important in several clinical settings. In pre-transplant evaluation, anatomic variants may influence the choice of surgical technique and determine surgical eligibility. In patients who have undergone transplant, an evaluation of anastomotic patency is required to help detect complications. The description of venous patency is important in patients with chronic liver disease and those at risk for HCC because of the high risk of vessel occlusions. If vessels are occluded, the report should include a description of the involved vessels, the type of occlusion, bland thrombosis or tumor in vein, and presence of cavernous transformation. The patency of arterial and venous anastomoses is an important element of the report in patients who have undergone transplant. Hepatic arterial anatomic variants should also be described, particularly in patients who are candidates for liver transplant or transarterial therapies. Biliary findings such as focal or diffuse ductal dilatation, causes of ductal dilatation if discernible, and gallbladder abnormalities should be reported. Similar to the vascular anatomy, biliary anatomic variants in transplant candidates and the patency of biliary anastomoses in the post-transplant setting are important reporting elements. Extrahepatic findings relevant to the clinical context include imaging signs of portal hypertension, like ascites or portosystemic shunts, spleen size, extrahepatic metastases, or other primary abdominal neoplasms, which help stratify risk and define treatment in patients with end-stage liver disease. The authors then go on to discuss the observations. This is a term I was not familiar with before reading this article. In LI-RADS, the term observation refers to an area with an imaging appearance that's distinctive from the background liver. It may consist of a pseudolesion or a true lesion, with the latter either malignant or benign, and of hepatocellular or non-hepatocellular origin. When multiple observations are detected, a decision must be made to report them individually, in aggregate, or as a combination of the two, depending on clinical context and observation category. The authors also describe findings important if your patient is considered for liver transplant or hepatic resection. Well, that's enough for now. Take a look online or in the print journal. Also take a look at the ACR RADS reporting systems on the ACR website. The number of these has really grown. And of course, the RSNA RAD Report template library, where you can find template suggestions for all specialties and pathologies. Okay, now let's move on to Dr. Frederick's summary.
Approach to cystic lesions in the abdomen and pelvis with radiologic pathologic correlation. Cystic lesions found in and around the peritoneal cavity can often be challenging to diagnose owing to significant overlap in imaging appearances. When the cystic lesion can be recognized to arise from one of the solid abdominal organs, the differential considerations can be more straightforward. However, many cystic lesions, particularly when large, cannot be clearly associated with one of the solid organs. Cystic lesions arising from the mesentery and peritoneum are less commonly encountered and can be caused by relatively rare entities or by a variant appearance of the less rare entities. The authors provide a summary of the clinical, radiologic, and pathologic features of various cystic and cystic-appearing lesions found in and around the peritoneal cavity, organized by site of origin. Emphasis is given to lesions arising from the mesentery, peritoneum, or gastrointestinal tract. When approaching a cystic lesion, the key imaging features to assess include cyst content, locularity, wall thickness, and presence of internal septa, solid components, calcifications, or any associated enhancement. In describing the cystic lesion, any deviation from the simple appearance should be described. Atypical appearances include multilocularity, wall thickening, internal septa and enhancement, solid internal components, and the presence of calcifications. Let's discuss cystic lesions of the mesentery and peritoneum, starting with benign true cysts. Peritoneal simple mesothelial cysts are congenital cysts formed in the small bowel, mesentery, mesocolon, or omentum. They usually contain serous fluid. Imaging reveals a simple appearing thin-walled unilocular cyst without internal septa. Chylolymphatic mesenteric cysts contain chylous fluid and originate from the small bowel mesentery. At imaging, they appear as unilocular cysts with a fluid level composed of non-dependent chyle. When assessing with real-time ultrasound, the contents can be mixed by shaking or moving the patient with reformation of the fluid level after 30 minutes of rest. On MRI, the fat content of the chyle can be shown as T1 and T2 hyperintensity with loss of signal intensity on T1 weighted, out of phase, and fat suppressed images. Cystic lymphangioma is a benign proliferative malformation of the lymphatic system. Pathologically, a lymphangioma is a thin-walled cystic mass with thin internal septa dividing the mass into multiple irregular spaces of varying size. The fluid contents are predominantly chylous but may be serous or hemorrhagic. Contrast-enhanced CT shows enhancement of the wall and septa. MRI is the most useful imaging modality to show the multiseptated cystic appearance characteristic of lymphangioma, which typically has high T2 and low T1 signal intensity. The presence of superimposed hemorrhage or infection may complicate the appearance of lymphangioma with all imaging modalities. It can mimic a solid lesion at non-contrast examinations. Now let's discuss cystic neoplasms of the mesentery and peritoneum. Extrovariant mucinous cystic neoplasm is lined by mucin-producing epithelial cells and occurs in multiple abdominal locations, most commonly the pancreas, appendix, and hepatobiliary tract. It can occasionally arise from the mesentery. It manifests almost exclusively in women. Grossly, mucinous cystic neoplasm manifests as a cystic mass with a thick fibrous wall. The loculi contain thick mucin or hemorrhagic necrotic material. At imaging, mucinous cystic neoplasm typically appears as a multiloculated cystic mass. Rim and septal calcifications have been described. As with other mucinous cystic neoplasms, solid or nodular components are rare, but when present should raise concern for invasiveness. Multicystic peritoneal mesothelioma, also known as a peritoneal inclusion cyst, is thought to be due to a chronic irritant causing non-neoplastic, reactive mesothelial proliferation and cyst formation, and is supported by the fact that it occurs predominantly in premenopausal patients who have functioning ovaries and pelvic adhesions with impaired absorption of peritoneal fluid secondary to pelvic surgery, pelvic trauma, endometriosis, or pelvic inflammatory disease. Multicystic peritoneal mesothelioma occurs most often in the pelvic peritoneum, in the cul-de-sac, or along the peritoneal surfaces of the uterus and rectum. It tends to be large, approximately 13 millimeters in diameter, and is mostly composed of serous fluid. At imaging, it appears as multiloculated thin-walled cystic lesions frequently adhered to the adnexa. Entrapment of the ovaries within the multiloculated lesion, the so-called spider and web appearance, is a characteristic finding. Pseudomyxoma peritoni is not a pathologic entity, but rather a clinical or radiologic term describing the finding of copious, thick, mucinous or gelatinous material on the peritoneal surfaces of the abdomen. They are most commonly related to appendiceal mucinous neoplasms. At imaging, pseudomyxoma peritoni is characterized as thick mucinous material found throughout the peritoneal cavity. When copious, it can exert mass effect on the solid organs, with a scalloped appearance along the surfaces, most commonly involving the liver and spleen surfaces. On CT, the mucin is hypoattenuating. Soft tissue attenuation septa and solid components, comprised of compressed mesentery, fibrosis, and solid tumor, and calcifications, may be present. CT is helpful in assessing tumor burden. Mucin tends to follow the route of normal peritoneal flow, with early mucinous deposits accumulating in the pouch of Douglas in females or the rectovesical space in males, then spreading to the right lower quadrant near the ileocecal junction, right subhepatic space, and right subphrenic space. Now let's discuss infectious and inflammatory cysts of the mesentery and peritoneum. Non-pancreatic pseudocysts are lesions arising from the mesentery or omentum secondary to trauma, surgery, or infection. They are sequelae of liquefaction in a hematoma or abscess that failed to reabsorb and are encased in a thick fibrous wall. CSF pseudocyst is a relatively uncommon complication of a VP shunt, thought to reflect fluid buildup after inflammatory reaction around the catheter tip, related to clinical or subclinical shunt infection after abdominal operation or shunt revision. Grossly, pseudocysts have a thick wall composed of fibrous tissue without a true epithelial lining. CT and MRI reflect this gross appearance and demonstrate a thick-walled cystic lesion and may contain a fluid level when it contains chylous fluid. Owing to the fibrous content in the wall, there will be progressive mural enhancement. Surrounding inflammatory changes are often present. Hydatid disease is a parasitic disease caused by echinococcus and transmitted to humans via the fecal-oral route. It is commonly encountered in the liver, but can be seen in the lung, spleen, kidney, heart, brain, and bones. Peritoneal hyatidosis usually occurs due to rupture of hydatid cysts in the liver or spleen. At imaging, a hydatid cyst appears as a solitary, unilocular lesion or multiple well-defined cystic lesions with or without daughter cysts. Ultrasound is the most common imaging method used to assess hydatid disease of the abdomen. It readily demonstrates the cystic appearance and the presence of daughter cysts, floating membranes, and internal debris. Hydatid sand may be visible when shifting the patient's position during the examination. At MRI, the cyst wall has low T2 weighted signal intensity due to the abundant collagen content of the pericyst. Textuloma and gossypiboma are non-medical terms used to describe a mass of cotton matrix unintentionally left in a body cavity after surgery. CT is the imaging study of choice for detecting gossypiboma and its potential complications. The typical appearance at CT is a low attenuation heterogeneous mass with an external high attenuation wall and a spongiform pattern containing air bubbles. Most surgical sponges have a radiopaque marker seen at CT as thin curvilinear metallic attenuation, which is pathognomonic when present. Now let's discuss cystic lesions of the GI tract. There are two main patterns of enteric duplication cysts: spherical cysts, which do not communicate with the lumen, and tubular cysts, which frequently communicate with the lumen. Enteric duplication cysts can be complicated by obstruction, intussusception, or bleeding. They can harbor ectopic gastric or pancreatic mucosa, leading to inflammation, bleeding, ulceration, or perforation. Pathologically, enteric duplication cysts arise from the mesenteric side of the bowel and is again defined by an alimentary epithelial lining, an envelope of smooth muscle, and attachment to the GI tract. Mucinous neoplasms of the appendix are mucin-producing epithelial tumors classified into four types: adenoma, low-grade appendiceal mucinous neoplasm, high-grade appendiceal mucinous neoplasm, and mucinous adenocarcinoma. These tumors are typically asymptomatic and discovered incidentally at imaging, but occasionally patients present with acute appendicitis or other nonspecific abdominal symptoms related to peritoneal spread. These neoplasms commonly appear as an appendiceal mucocele, a macroscopic description of an appendix abnormally descended with mucin. Imaging demonstrates a markedly dilated appendix, possibly shaped like a pear or chicken drumstick, frequently with mural calcifications. The presence of an appendiceal mucocele should prompt a search for extraluminal mucin. Low attenuation deposits limited to the periappendiceal region or disseminated throughout the peritoneal cavity. The anatomic location and imaging features of a cystic lesion encountered in the abdomen are the most important factors to consider when establishing a radiologic differential diagnosis. The lesions highlighted in this article arise from the mesentery, peritoneum, or gastrointestinal tract. However, these and other cystic lesions may arise from solid abdominal organs or from pelvic organs as well. Hepatic and splenic origin cystic lesions can be classified as developmental, inflammatory, neoplastic, or trauma-related. The most common are simple liver cysts and biliary hamartomas, usually encountered incidentally at imaging. Pancreatic cystic lesions include pancreatic pseudocyst, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, serous adenoma, and solid pseudopapillary neoplasm, which have defined imaging features. Cystic degeneration or necrosis within a ductal adenocarcinoma, neuroendocrine tumor, or acinar cell carcinoma may also have a cystic appearance. In the pelvis, cystic lesions can arise from the urachal remnant or reproductive organs. Residual patency of some or all of the urachus can lead to a cystic appearing lesion in the anterior pelvis, characteristically between the anterosuperior bladder dome and umbilicus. Cystic lesions arising from the ovaries are common and are frequently encountered incidentally at imaging performed for evaluation of pelvic and abdominal complaints. Determining adnexal origin can be difficult for large lesions. When the cystic lesion is large, determining the site of origin may be difficult, forcing reliance on imaging features to establish the differential diagnosis. Locularity and the presence of solid nodules are the most useful features, serving as a basis for an algorithmic approach to making the diagnosis or establishing a useful differential diagnosis. Unilocular cysts without solid nodules are non-neoplastic. Mesenteric true cysts are thin-walled without septa. Enteric duplication cysts are thin-walled with septa. Non-pancreatic pseudocyst and gossypiboma are unilocular with a thick fibrous wall. Mucinous neoplasm should be considered for a unilocular cyst with solid components, which may arise from the appendix or mesentery, pancreas, ovary, or liver. Multilocularity can be present in neoplastic, infectious, inflammatory, or congenital lesions. Thin-walled multilocular cystic lesions without solid nodules are almost always benign, with the exception of pseudomyxoma peritoni or mucinous carcinomatosis, which should be considered when a mucinous neoplasm is present. The presence of solid nodular components in a multilocular cyst should raise concern for malignant or malignant potential neoplasm. Specifically, thick-walled cystic lesions with solid components should raise concern for mucinous cystic neoplasm or ovarian cystic neoplasm. Surgical resection is the treatment of choice for most cystic lesions in the abdomen. True cystic lesions are benign and have a highly favorable prognosis. Total excision is curative with minimal risk of complications and no risk of recurrence. Pseudocysts are less often excised, with medical therapy, drainage, and marsupialization more commonly used. CSF pseudocysts are typically managed by removal of the catheter and administration of antibiotics.
Wow, there's so much. And it's hard. I had to call Dr. Frederick the other day because I had a cystic mass in the abdomen as a corner shot of my spine study. But now that he's explained this, maybe I can do it on my own. And you have to see the print journal or online version of this article. The pathology pictures are incredible and really gross. Okay, we'll be back in 2 weeks with more summaries. In the meantime, check out the website and Twitter for more cases and information. And I hope you're registering for RSNA. I'm really excited to see everyone there.